Okay. I think, ma'am, we can start.
Yes,
Yes.
please.
Yeah. Good afternoon, one and all. I, Dr. Madhura Kelkar, I welcome all of you for this cutting edge webinar series on behalf of Pune Obstetrics and Gynec Society. So, this webinar, just as a short introduction, we've been having this webinar since a couple of months every Tuesday afternoon, 4 to 5 p.m. This was the brainchild of Dr. Meenu Agarwal, ma'am. We started this webinar with the aim of spreading knowledge about infertility, ultrasound, etc., with various societies all over the country. So we have successfully been having these webinars over the past few Tuesdays, and we all enjoy it. And I think all the delegates also enjoy it. And more than that, I think the interactions that we have with different society is uh, is very good and it's very encouraging. So I would request Dr. Meenu ma'am to just welcome our dignitaries so that we can start the webinar.
So good evening, everyone. On behalf of Pune Obstetric and Gynecological Society, I welcome you all. We have stalwarts of Foxy today with us. We have Dr. Sudhir sir with us. We have Dr. Deepak sir with us. And I have been seeing them like for so many years in Foxy. So all Foxy meetings, Foxy man, and we always look
Yeah,
at them.
we have been born at Foxy.
Sir, sir, अब down of Foxy के sir इतनी respect से and they we look at them and we have always been very revered teachers and very revered personalities. So very happy to have both of them with us today as guest of honor. We also have Dr. Arpit Vachnani and Dr. Chetna Shah. I can see them over here from Surat. So very welcome to both of you. And also from Rajkot, Dr. Radhika and Dr. Milan Wadekar. He looks so young and he said he's been past president like 3-4 years ago. So very nice, very good achievement on that. And we have Dr. Dhwani Desai again from Surat. She will be speaking on the joyful motherhood lecture today. So I am very happy to welcome all of you and with my entire team, Charu, Lata Bapai, Vaishali Chavan, Amol Lunkar, so and the POGS president and secretary. For this entire team, I welcome all of you with folded hands, and I am very happy to see you and have you over here.
Good afternoon,
Thank you,
everyone. It's very pleasurable to be with all of you, and we are also going to be happy sharing knowledge with you. So we can start with the first session. Madam Meenu Agrawal is going to.
Ma'am, ma'am, just 1 minute. We'll just have a small prayer song and then we'll introduce our chief guest and then we'll begin the first session, ma'am. Okay. Thank you. So with the lamp lighting, we are done with the inauguration of the webinar. Now I request Charu ma'am to introduce our chief guest, Dr. Deepak Bhagde sir. Charu madam is there?
Yes, so
Charu
shall
ma'am is or otherwise
okay.
I request Amol Lunkad sir to do his introduction.
Yeah, good evening to all of you. From Pune Obs Gynae Society, as the clinical secretary of Pune Obs Gynae Society, at the outset, let me thank Surat Obs Gynae Society and Rajkot Obs Gynae Society for giving us this opportunity to interact with you all. It is our privilege today to have
We have two guests of honor, both guests of honor. Amol.
Dr. Deepak Bagde sir. You are able to hear me?
Yeah, you're full
Yes.
clear.
Yeah, so sir has been at various positions and he has been a senior patron of Foxy. He has been the past president of Saurashtra Obs Gynae Society, that is the All Gujarat Gynec Obstetric Societies. He has been a postgraduate with a gold medal from Ahmedabad. He has been the head of department of the MP Shah Medical College, Jamnagar, and he has given the first ever Saurashtra Obs Gynae Society oration. He has delivered about 63,000 plus IVF babies in his private practice. So it is a privilege to have such an experienced personality with us today. Uh, Over to Madhura, yes. Yes, sir. Madhura?
Yes, sir.
Yeah, and Madhura, shall I go ahead and introduce
Yes,
Dr.
sir. Yes,
Yeah,
sir.
so another, again, well-known personality from Foxy, Dr. Sudhir Shah sir is here as the chief guest with us. And he has been basically a senior consultant from Rajkot. He past president of Rajkot Obs Gynae Society, ex-assistant professor of Baroda Medical College. He has authored several books on obstetrics and gynecology, and he has been basically well known for his SRS needle for NDVH surgery. He delivered the Ahmedabad Obs Gynae Society oration on NDVH in 2017. So, thank you, sir, for being here with us. Over to our chief guest and guest of honor for your blessings.
Yeah. So we can start with Deepak sir and then Sudhir sir. Sir.
Yes.
Yes, sir. You're muted, sir.
Deepak sir, you're on mute.
Okay. It's always a pleasure to be with Minu and POGS.
Thank you, sir.
POGS is, let me tell you, is my almost as a sister society in the sense that lots of times I've been to Pune Obstetric Society when my daughter was studying in DY Patil. And since there's a good friend, started with Dr. Nargolkar and his has forceps. And fortunately, I'm one of the recipient of his original hair forceps because he saw that I'm still using those hair forceps. And yes, with Sanjay Gupta, Sunita, and all of you, Pune is always in my heart. And now, Minu, coming to this webinar, as I said earlier, before everyone joined, how you people really manage so many webinars. But yes, it's really great teaching to the people who cannot really, of course, all of us cannot afford to spend so much time in conferences, and so webs have been a good thing. But sometimes I really feel it is order. Let me be very frank also to that also.
Absolutely.
But yes, it is a good learning for everyone. So very happy for the company today, and of course the web part and the learning part. Minu, all the best for your all the endeavors, especially for your VP's post. All the best, and thank you for getting me in this again.
Thank you, sir. Thank you very much, sir. Thank you for these kind words, sir. And we are also attached to you the same way you are attached to POGS, sir. Sudhir sir.
Sudhir, unmute.
Sir, unmute, please.
सर आपको अनम्यूट करना पड़ेगा सर.
Milan, send request to sir to unmute.
Yes, sir, already sent.
Okay.
Can you unmute from your end?
No, ma'am. Only we can send the request.
Yes. She's
Hello.
on. Huh.
Is it okay now?
Yes, sir.
Hello.
Hello. Sir.
Is it okay?
It's okay, sir. It's fine, sir.
Okay. Thank you very much to the Pune Obstetric Society for inviting us as a guest of honor here. It's one thing is common between the Pune Obstetrics and myself is the age of establishment and date of year of the birth. 1953 I was born, and the Pune Obstetric Society established in 1953, if I am not wrong. So it's a sibling effect over here, and I congratulate to the Pune Society for having this webinar on cutting edge on different subject every Tuesday. That is a big job, and I also welcome and Dr. Radhika from Rajkot and Dr. Chetna and Dr. Milind and Dr. Arpit from the Surat Obstetric Societies, for which these two societies and Pune Societies doing a wonderful job. Today's both subjects are gonadotrophins and the intra care of the mother. Both are very interesting subjects, and gonadotrophin particularly to the general obstetricians and gynecologists would be very beneficial because they use the gonadotrophin very commonly while doing the obstetric practice, so they don't have much time to read in details about the infertility patient, but such webinars will help them. Intrapartum care is a very important thing because the tender care taken during the intrapartum period, even if you touch the head of the patient mother, it would be a great relaxation for them. So I wish all the best to the speakers, Dr. Binu Agarwal and Dr. Dhwani Desai, and my special congratulations to Dr. Madhura Kelkar for managing everything. Thank you very much.
Thank you so much, Dr. Sudhir Shah, sir. It is indeed a pleasure to see both you and Deepak, sir, on screen. And your friendship, your blessings, your words of wisdom, your constant guiding force. Whenever you meet us, you always have some take-home message for us, and that really keeps pushing us forth. So thank you so much for being here and for blessing this webinar. I just got disconnected for some, I think my net went off. So I was not there to introduce you, but yes, I just thought let me.
Thank you very much for my time.
Yeah. Thank you so much. Thank you very much.
You can start.
Thank you, sir. Thank you for these kind words. And like Charu said, whenever I also have that same feeling, Charu. Whenever I meet Sudhir sir or Deepak sir, हमेशा एक वो positive vibes आते हैं ना, as if they are blessing us. हाँ, go ahead, do it. That is the vibes that we get with them. Very, very positive. So thank you for that, sir. Thank you so much.
So with that, we come to the end of our inauguration function, and we can move ahead with the academic session. Over to you, Dr. Madhura.
Madhura ma'am, you are on mute.
Sorry. So let's begin our first session where Dr. Meenu Agarwal madam will be delivering her talk. For the same, I would like to invite our esteemed chairpersons, Dr. Arpit Vachani and Dr. Chetna Shah. I request Dr. Charu ma'am to introduce both our chairpersons.
Indeed, a pleasure to do so. Dr. Arpit, she has always been so cooperative, so insistent. When they are having their Surat, they are having a conference in Surat. She took great efforts to invite me, but unfortunately, I'm not there. And that is exactly how I connected. And so I felt so nice to invite her for this particular webinar. Dr. Arpit is a consultant obstetrician and gynecologist and menopause consultant at Atmiya Hospital, Surat, since 21 years. She has done her MBBS and MD from Jamnagar and DNB and MNA MS from AIMS, New Delhi. This just shows her dedication towards medicine and her, what a true academician she is. She's the secretary of the Surat OBGYN Society for this particular year, and she's a credentialed IMS menopause practitioner, ex-assistant professor at GMC Surat, and has worked for her society to a large extent. She's a master trainer, Dhira Project by Foxy, and has participated in various conferences. Welcome, Dr. Arpit. Pleasure to have you here today. And our next chairperson for this session is, can I have the next CV, please? Prasad?
Yeah, Chetna
Yes.
madam.
Yeah. So, Chetna madam has been awarded 2 gold medals and the President's medals for first among all lady students. Big round of applause to you, madam. She has passed her MD DJU in 1984, chief gynecologist at SDA Mission Hospital from 1985 to 1989, and started private practice in 1989 till today at Anand Hospital. She has a keen interest in endoscopic surgery and was part of the laparoscopic surgery workshops conducted at Anand Hospital 2009, 2011, and 2019. She also has a keen interest in high-risk obstetrics and has delivered a number of public awareness lectures and talks. Welcome, Dr. Chetna. Over to you to introduce our speaker for today and to conduct this session. Dr. Arpit, you could introduce, madam.
Good evening, everybody. It's a pleasure for Surat Society to be with you all, and it's my privilege to introduce Dr. Meenu Agrawal, madam. But before that, I would like to invite all of you to our Foxy Presidential Conference in Surat in July. And I have words of praise for our Dr. Deepak Bhagde sir and Dr. Sudhir Shah sir. They were the first to register for the conference from outside Surat. So a big round of applause for such seniors when they are encouraging us for such a big conference. It gives us, it really boosts our morale for the conference. So thank you, Sudhir Shah sir and Deepak sir for the same. And now introducing Dr. Meenu Agrawal ma'am. She is the immediate past president, Pune Obstetric and Gynec Society. She is the elected Secretary General, International Society of Gynecological Endoscopy, and was the chairperson of Foxy Imaging Science Committee from the year 2018 to 21. She is the course director of endoscopy and ART training courses in UAE, and she has over 12 publications in international journals and has authored many books and chapters in various books. She is the bachelor in reproductive endoscopic surgery, and that is European board certified. She has many awards to her thing, and she's the India's greatest leader award by Asia One and the Foxy champion of Foxy award. So it's my privilege to have you here, ma'am, and to listen to you also. And she'll be speaking on the topic use of gonadotropins in IUI, when, how, and how much. So over to you, ma'am.
Thank you so much, Dr. Arpit, for this elaborate introduction. We will be coming for your July conference, so please.
Yes, ma'am. Sure. We'll wait for you.
Yes. And Dr. Chetna madam also, thank you very much for chairing this session. And I shall be talking today on this very simple topic, but sometimes it can get a little confusing, which is how to use gonadotropins in IUI. Is my screen visible?
Yes.
Yeah.
Yes.
Okay. Thank you very much, sir. So, good evening, everyone. This actually, when we started this webinar, we called it a cutting edge webinar because we tried to bring in some slightly advanced topic, which is but day-to-day topic, along with some obstetric topic, generally on how to take the labor, make it joyful motherhood. So this combination of these two, and the people, most of the people who are attending, the delegates, the doctors, friends, colleagues, they have actually liking this webinar very much, and I keep getting the inquiries on the next cutting edge webinar, what are the topics. So today we took a very simple topic on gonadotropins in IUI. What is the safety? What is the efficacy? Now, before I touch upon this topic, I thought I should add this particular slide of ART law. अभी जो ART law नया आया है 2022 में, which got slightly modified. तो what does that ART law tells us? एक तो oral agents जैसे letrozole है, clomiphene है, that can be given by any gynecologist. without any registration under ART law. However, if we want to give clomiphene or if we want to give letrozole followed by IUI, then it can only be done by a gynecologist with level 1 ART clinic registration, wherein you have to pay 50,000 to the state authorities. They come, they
As I
inspect.
told you,
There is
ductal ectasia. म्हणजे त्याचे duct
there are some requirements which I am not discussing here. So that is level 1. Now, suppose we are using gonadotrophins. I have given clomiphene, it did not work. I don't have any registration for an infertility clinic. I want to use HMG or FSH, maybe for timed intercourse or for gonadotrophins followed by IUI. This can be done by a gynecologist with at least level 1 ART clinic registration. तो हम लोग अभी लिख के नहीं दे सकते पेशेंट को कि आप HMG ले लो, आप SCG ले लो. So all these have now come in the ambit of ART law, and level 1 registration has to be done to start with these gonadotrophins. If the patient is for IVF, for any kind of pickup and ETs have to be done, then it has to go for a ART level 2 registration. Having said all of this, I must share this incident. Yesterday, I told a patient that I will start you on Gonal-f from tomorrow. You come and you start taking the injections from the clinic. And today she called and she said, no, I picked up the pen from my nearby pharmacy and I will take the injections at home. So they are so easily available without any prescription. She got the injection from the pharmacy. So I think all the restrictions are for us doctors, but still we have to follow the law because you don't want to do something which is not lawful in a clinical practice. Now, although gonadotrophin therapy is become very important in a fertility treatment, we are still little skeptical, little diffident कि उसके क्या रिस्क होंगे. Of course they are expensive. कितना carefully हमको use करना है. And what all do we have? We have HMG, we have purified FSH, we have highly purified FSH, we have SCG. These are the urinary products, and then we have the recombinant products which are FSH, LH, and SCG. What is the difference? Why do I say this is urinary, this is recombinant? See, urinary products are formed from the urine of postmenopausal women. That urine was collected, it was filtered. HMG was obviously they have high FSH LH levels. It was extracted, and that is how urinary HMG came into picture. And from the urine of pregnant women, we get SCG, and that is urinary SCG. Now, recombinant molecule means that it is by a recombinant gene technology from a Chinese hamster, and now they have created the cell line. Now, वो cell line से you can get FSH, LH, SCG. Now, what is the difference between the two? अभी एक mind में रहता है, should I use urinary? Should I use recombinant? Is recombinant better than urinary? Last time I used urinary HMG, I didn't get the pregnancy. Should I use a recombinant FSH this time? So when we look at these two molecules, there are few things that we should keep in mind. Urinary there can be batch to batch inconsistency, especially for IVF cycles. Recombinant generally it is same because ये तो lab में बन के आ रहा है, तो there is no batch to batch variability. Urinary will have some upper limit. कितना urine we are taking from the women and from there we are extracting. It's a human source. Recombinant, since it is produced in the lab, there is no upper limit. You can make how much ever you want. And then of course we have the down regulating agents, agonist and antagonist, which also we might use in some cases in IUI. When I say 75 units of HMG, that means it is 75 units of FSH and 75 units of LH. But when we are giving on day 2, day 3, day 4, we are only using the 75 units of FSH because there are no LH receptors there. because there are no LH receptors, so only FSH is being used, even though we think that we are giving HMG in a PCO patient, will it harm the patient, or we are using FSH in a normal patient, should we use HMG? It may, when we purify it, we remove the impurities. The more we remove the impurities, it becomes highly purified HMG. We remove more and more LH, it becomes purified FSH, and then we have recombinant FSH and recombinant LH. Both are available in the market, so you can use any of these. Initially, the gonadotropins were extracted from a female horse or a mare, but they realized that there were a lot of immunological reactions to the patient, so it was taken off the market, and then they started using from the human source. Now, one very important question that we have is how to use it in IUI. So, what do we want in IUI? One is 2 to 3 mature follicles. The endometrial thickness should be more than 7 millimeters, and we should do the IUI around the ovulation time. This is our goal. This is what we want in an IUI cycle. What all we can use? We can use clomiphene citrate. We can use, well, clomiphene citrate is not out of the window yet. There are people who like clomiphene citrate and they still use it. Letrozole. Then we have a combination of oral drugs with gonadotropins, or we can use only gonadotropins. If it was in-person lecture, I would have said where will we use only gonadotropins. So that probably the answer would be in PCO patients. Now, what are the indications? Suppose हमने clomiphene citrate दिया या letrozole दिया patient को, no ovulation, right? So you have given it, but there is no ovulation. 2 or 3 cycles, you have increased the dose, no ovulation, then you go for the addition of gonadotropins. Or there is ovulation happening, but no pregnancy. So you have tried 2 or 3 cycles, ovulation is happening, but there is no pregnancy. So these are the two indications where you would use. That is, first is called the clomiphene citrate resistance, as we used to call it, that we are giving it, but she is not responding, or failure, where we have given it, she is ovulating, but she is not conceiving. Then we, of course, have patients where we have thin endometrium, so we do not want to use clomiphene citrate. We may use letrozole, or we may use gonadotropins, and then, of course, hypogonadotrophic hypogonadism. Now, slight thing about this. Suppose you get a 15-year-old girl, primary amenorrhea. She comes with her mother. You do a routine checkup for her. Everything seems to be okay in your opinion. You get an ultrasound done. Ultrasound shows small sized uterus. Bilateral ovaries are normal. There is no septum, no transverse septum, no hematometra, And then you do her FSH-LH, and the FSH-LH are low, right? So then you say, okay, she is a hypo patient. How do I treat this patient? WHO group 1. So this patient is not getting menstruation because there is no FSH or LH which is acting on the ovary. That is why the ovary is not producing any estrogen or progesterone, which is not acting on the uterus. So there is a end organ, estrogen and progesterone is not there. So we give her counseling, again very, very important, huge counseling we require, because she has to take estrogen with progesterone for a very long time. Till when? Till she gets married and she actually wants to have a child. And when she wants to have a child, that is the time we will use HMG. Only thing which will work for this girl is use of gonadotropins, because clomiphene citrate will not work, letrozole will not work, because they are working on HPO axis. Her HPO axis is not working, so we need to give her HMG. So hypo patients, for stimulation, we need to give them gonadotropins. Also, where mild to moderate male factor infertility, you are doing IUI for her. She has endometriosis or she has unexplained infertility. These are basically where you are doing IUI, and then you are also adding the gonadotrophins. So when we see gonadotrophins plus IUI, what are the clinical pregnancy rates? Around 35%. Clomiphene citrate still takes a edge over letrozole. The pregnancy rates are slightly higher with clomiphene citrate as compared to with letrozole. So 22% with letrozole and 28% with clomiphene citrate. When you add gonadotrophins, the pregnancy rates they go much higher. So this was again a meta-analysis of 26 RTCs you see here, and it has shown that gonadotrophins significantly improve both the live birth and the ongoing pregnancy rates as compared to the clomiphene citrate. Now, very important before we start with any stimulation, sometimes we get patient was given 2 cycles of letrozole, married for 8 months, not conceiving, regular cycles just given, but husband analysis was not done. So that is again very, very important. First and foremost, we have to do husband's analysis, even if we have to start clomiphene or letrozole. So don't start gonadotrophins unless you have the report. And in our center, because ours is an tertiary IVF center, so the moment the couple walks in, the history is taken. By the time wife is comes for the ultrasound, the husband goes for the semen collection. So everything is done simultaneously. It is like one stop shop kind of a thing, that everything is done at the same time. Very important again to evaluate the lady before we start with any kind of stimulation for her. A good ultrasound. Today, I would say a good ultrasound, and of course, any IUI. We do not do IUI without confirming that the tubes are patent. You can do HICO-C, you can do sonosalpingography. We generally do HSG. As per the ASRM guidelines, there is no role of laparoscopy for the tubal patency. So that we can do, and there is no role of diagnostic laparoscopy in infertility. No role. No role of diagnostic hysteroscopy, no role of diagnostic laparoscopy, because we have excellent imaging techniques which are available. If at all you want to do a laparoscopy for a patient who's infertile, you are suspecting but you are not sure, please do not write diagnostic on your, write fertility enhancing laparoscopy, because in case you go in, you find some mild endometriotic spots which you did not see on ultrasound, then at least you can coagulate them and you can take care of that if you have mentioned fertility enhancing laparoscopy and not diagnostic laparoscopy. Same with hysteroscopy, it is always see and treat procedure. So don't write diagnostic hysteroscopy, write fertility enhancing endoscopic surgery or fertility enhancing hysteroscopy. So if you find a small adhesion band, you are not going to come out and then take the patient under anesthesia or even an office procedure again to do that procedure for her. Then, how do we do the clomiphene or letrozole? Now, this is a very regular thing that we think that we start with letrozole or clomiphene, and from day 7 onwards, we start with gonadotrophins. Am I right when I say that I start gonadotrophins on day 7? I think this also has to be seen when to start the gonadotrophins. Now, if you look at this particular graph, these are the primordial follicles here, which is developed into antral follicle. This is on day 2. Okay, so this antral follicles, apne day 2 pe sonography ke, this is what you see. This may be on day 6, day 7, or day 8 that you have a selected or a dominant follicle. Now, once you see a dominant follicle, that is when you should add the HMG. What happens अगर हमने यहाँ पर HMG शुरू कर दिया, that there is no dominant follicle still, then all these follicles will come up, all these follicles will start growing. So all of us have had, in my initial years, I have also had this issue that I started for IUI, I gave 5 days of letrozole, I started HMG on day 6 or day 7, and suddenly I find 3 or 4 follicles coming on both the sides. So in a natural cycle, one follicle becomes, it gets selected, it becomes dominant. Once it becomes dominant, it starts secreting more estrogen, more FSH. This estrogen goes to the HPO axis and it tells the other follicles to undergo atresia. While the other follicles are undergoing atresia, this is a selfish follicle. It is secreting its own FSH. So even if there is no FSH coming, this follicle is growing well, and at some point of time it undergoes ovulation and it releases a mature oocyte. So this is what happens in a natural cycle. So this is how we must go ahead. So suppose if we see 2 follicles here, one and one more follicle, 2 selected follicle, out of which in a natural cycle one would have grown. But if you add HMG here, you can get both these follicles growing, and that may give you a better results of IUI. So you give HMG when you have 1 or 2 selected follicles, and that is when you give HMG and take these follicles to the ovulation. So suppose you are going in a doing a clomiphene citrate cycle, and you find the endometrium is not so good, it is okay. In that case, again, if I have to add estrogen tablet, if I add here, estrogen will go to the HPO axis and give a negative feedback for FSH, which we do not want, right? So when should we add estrogen? Always when you have added gonadotrophins. Once you have added gonadotrophins, the negative effect of estrogen, even if it is there, you are giving exogenous gonadotrophin, so it will not harm the follicle, the growing follicle. So once you see 1 or 2 dominant or selected follicles, you have added gonadotrophins, that is the time you can add exogenous estrogen if required in some group of patients where you have a challenge with uh, thin endometrium. So that is what we have to keep in mind. Then again, as I said, we can go either with gonadotrophins, this we already discussed. So how do we do it? Whether we should give it every day or whether we should give it on alternate days. Many studies, it actually does not matter. Once you see a dominant follicle, you can give every day 75 or you can give alternate days 150. Actually does not matter. However, this was one published paper where they gave better clinical pregnancy rates with daily FSH as compared to on alternate days. How in my clinical practice, I don't find much difference, but this was a good paper where they said a daily dose is better. कितना देना है, how much to give, whether I should give 75, I should give 150. So it will depend on what is the age of the patient, what is the AFC count of the patient. So you can give 50 international units, 75 or 100 depending on what is the. So this is a nice graph. This is the weight of the patient. You can take a screenshot of this. So this is the weight of the patient here. This is the total number of antral follicle count इतना है. तो अगर antral follicle count suppose इसका for example 5 है and the weight is 60 kilos, so you should give 75 international units. However, if her antral follicle count is 5 but her weight is 75, then you should give 100 or 150 units. If she is total number of follicle is very high, suppose it is 20, weight is say, although she's 50 kilos, again here you should use lesser dose because otherwise all the follicles will come up. So this is how you can also calculate the dose of the patient, how much to give. So this all right. So then there are a few different protocols. One is a step up protocol. Step up protocol usually we use for PCO patients. Okay. In fact, we start with 37.5. So we give 37.5 for 5 days. After 5 days, you do the ultrasound. If you find a dominant follicle, 1 or 2, then you continue with the same dose. If none, then you increase it to 75. Again, you wait for 5 days. If you find at least 1 or 2 dominant follicles, you continue with the same dose. If none, then you increase it to 150. Give it for 5 days. Again, if you find, see, the idea is to reach the threshold for one follicle to grow and not make all the follicles to grow. Every patient will have a different threshold. That is why we have to start with a lower dose so that we know what is the threshold and then go higher and higher. You can go up to 225. There is no problem. Then we have something called a step down, which we don't use for IUI patient. We mostly use it for IVF patients where we maybe want a lesser number. Now with all this new law coming up, you may have to reduce the dose because you want lesser number of follicle. With the new law, you should try and get only 7 oocytes from a donor. So if you feel that the more follicles are coming up, then you reduce the dose, the smaller follicles will die out and the bigger follicles will survive. All right, so this we already discussed. And as I said, what to use, whether I should use HMG or I should use FSH. So if we look at both the Cochrane data for both of them, there is no difference in live birth rate, OHSS, or any other outcome. That means we can use recombinant FSH, urinary FSH, or urinary HMG. So, whatever is effective, cost effective for the patient, you feel that okay, this patient cannot afford a recombinant, we can go for urinary. There is absolutely no problem. Recombinant is slightly more expensive as compared to the urinary products. PCO patients, again, whether to use HMG or FSH, again, there is no difference in live birth rate. So, the earlier thought process ki PCO hai to we should not use HMG, there is no problem, we can use HMG. Again, in PCO patients, you can use a combination with letrozole, start letrozole or clomiphene day 2 to day 6, do the ultrasound, you find 1 or 2 selected dominant follicles, you add HMG. If you are not getting any response from either clomiphene or letrozole, then you can go for only gonadotrophin. So gonadotrophin, you start from day 2, low dose, 5 days tak wait karo, 5 days ke baad do the ultrasound. We can also do the E2 values, but ultrasound will tell you whether there is a follicle or not. If there is a follicle growing, then you continue with the same dose. It is not difficult at all. We do it all the time, PCO with gonadotrophins. Don't get scared. It's day 2 se shuru kar rahe hain, some problem will come. Nothing will happen. You start with the low dose and then monitor it well. The most important part that we should monitor it very, very well. So how do we monitor it? We actually monitor on ultrasound. Ultrasound is excellent. If you have any doubt, then we do the E2 values. Okay, E2 बताएगा कि आपका follicle grow कर रहा है कि नहीं कर रहा है, because E2 is secreted by the follicle. Okay, and progesterone will tell us whether this follicle is getting luteinized. So these are the two things that we have to keep in mind. So we do E2P for all the time. Okay, so that is again important. Now, whenever we are measuring the follicle size, it should always be measured in 2 diameters. One like this, and then second intersecting the first one at perpendicular. And most of the modern machines will give you the average of these 2 diameters. Automatically it will come. So the endometrial thickness is also growing, the follicle size is growing, E2 values will also grow. Suppose आपने E2 आज किया, if you have any doubt, suppose you have done a sonography on day 11 and you see the follicle is there but it is looking very flaccid. It is not looking like a strong follicle. So it's a 17 mm follicle. There's another 14 mm follicle. 2 follicles are there. You put the color Doppler. 17 mm follicle does not have a good blood flow. 14 mm follicle has a good blood flow. Okay, so you are thinking whether I should give HCG or not. You do the E2 value. Now, E2 will not correspond to your larger follicle. 200, normally a mature follicle will release about 200 picogram of E2 values will come between 150 to 200. So if your E2 is come like 120, that means the smaller follicle is the one you have to focus on. Wait for 1 or 2 days, let it grow to 17 or 18, and then you give the trigger with HCG. So that is one important thing that we have to, a good ultrasound we have to keep in mind. अगेन समटाइम्स कभी रेडियोलॉजिस्ट ने आप खुद नहीं कर रहे हो सोनोग्राफी रेडियोलॉजिस्ट के पास, तो वेरी इंपॉर्टेंट टू टेल द रेडियोलॉजिस्ट प्लीज डू ओनली टीवीएस, क्योंकि वो लोग कभी टीवीएस नहीं करते. दे विल ऑलवेज से पेशेंट डज नॉट वांट इट, ब्लैडर वाज नॉट फुल, और आई मीन और bladder was full but patient did not want to do a transvaginal sonography. So that is again very very important that we have to keep in mind. Smaller follicles should always be also mentioned, not just the leading follicle. So that is again very very important. This is a graph we normally in clinical practice we don't go by this graph, to be very very honest. If you see any follicle between 15 to 20 mm, you can give a trigger with HCG. Okay, there is no problem at all. Now another thing which we have to keep in mind, sometimes you have done a sonography today, suppose आपने सोनोग्राफी किया, सोनोग्राफी पे you can see cumulus, you can see a free fluid around the follicle, and you can see some lot of color Doppler पे lot of blood supply. Now it could be, if you do PSV, it will be very high, 25. That means it is pre-ovulatory. You do the LH surge, LH test. Urine LH is positive, or if you have done a serum LH is more than 11 or more than 12. इसका मतलब उसको LH surge already आ गया है. If she has already got an LH surge, she will ovulate anytime. So do not wait to give SCG and do IUI 36 hours later. Do the IUI today only or tomorrow morning. Okay, so to catch the right time of ovulation on ultrasound is again very very important. So if we have to give HCG, we should give it a day prior. If you already see the ovulation almost happening, then the HCG will not cause any harm, but it is not going to help us because the patient will have already ovulated. So that we have to keep in mind. Suppose you have done an IUI cycle, you see suddenly you see lot of follicles here. Okay, day 9 you don't see one dominant, there are many follicles. See, there's so many follicles which have come up, all follicles are there. What to do next, what are the options? तो ये मेरे पास भी कभी कभी कॉल्स आते हैं, मैडम और डॉक्टर मीनू वी आई डिड वन साइकिल फॉर IUI and I can see 3 follicles on one side and 4 follicles on one side. They're all 15 16 in size. What do I do? So what to do? First thing is that we can, if there is a long standing infertility, we can convert it into an into an IVF cycle. That is one possibility. How to convert it into an IVF cycle? Sabse pehle you give her 1 dose of antagonist so that she does not ovulate. Once you have given antagonist, it is under your control. Then you can give 1 or 2 days of gonadotropins, let these follicles along with antagonist, so LH is suppressed, and then you give HCG, and then you do pick up 36 hours later. So that is one option that is there. What is the second option? Is cancel the cycle. Now when I say cancel the cycle, what does it mean? Should I just send the patient home? No. When I say cancel the cycle, one thing I have to keep in mind that this patient can have a natural LS surge. Endogenous LS surge can happen for her. We have not counseled her very well, or we have counseled her, husband is not coming with her, he does not listen, and they still happen to have intercourse, and there is a possibility of multiple pregnancy. So multiple pregnancies can happen, 4 5. You sometimes we do read in papers 5 babies or 6, these are not because of multiple embryo transfers. These are because of these, either sometimes even with clomiphene citrate cycles, where the patient just did not come for a follow-up and she developed multiple follicles, endogenous LS surge, and then so many pregnancies have implantations can happen. What are the other thing that we can do, which so if I want to cancel the cycle, I explain to both husband and wife, that is one. Second thing is, I put her on antagonist. If I give her antagonist, it will suppress her FSH and LH, so these follicles will die out. So I give her antagonist every day for next 2 or 3 days. I give her progesterone, simple medroxyprogesterone, again 1 BD, say maybe for 5 days or 7 days. Once she gets her next cycle, then your effect of this multiple follicle is gone. So you do not even want OHSS happening. So you give her medroxyprogesterone, you give her antagonist, you counsel them, and then in the next cycle we take precautions as to what is to be done for the next cycle. Again, sometimes we converting to an IVF cycle is again a very very good option, but provided the patient is ready for it. If it is a hyperstimulated patient, overstimulated, you do the E2 values, and suppose your E2 value comes more than 3500, that means this patient has higher risk of going in for a OHSS, right? So you have two options. One is you can give a trigger with agonist, and then you can still take precautions, give her caberlin, give her antagonist, give her plenty of fluids, and you have to take care of how much urine she is passing, if she is having any distension, is she having any breathlessness. So all that you have to monitor the patient. Or you can give her only antagonist, and again you have to follow the patient. You cannot have a patient who's come for having a child who goes into the ICU. So we cannot have that scenario. We have to be extra careful for this. This probably is one of the reasons why the government is trying to take even gonadotrophins in the ambit of ART law, so that everybody gets into the same comes under the same umbrella. Another thing which sometimes can happen is either a premature LS surge or a luteinized unruptured follicle in an IUI cycle. So that problem again, if you have a LS surge is positive, her ISHO test or the urine LH test is positive, but there is no rupture of the follicle. So the there we can, in the subsequent cycle, you can use the antagonist in those cases. So what will antagonist do? Antagonist will suppress the endogenous LH, and then only when you give SCG, that is when she will ovulate, and you can give higher dose of antagonist in those cases. And that is again one population where you can use gonadotrophins, antagonist, and SCG. So all these three together, and believe you me, we get excellent results, especially in unexplained infertility, mild PID, mild endometriosis, diagnosed unruptured luteinization of the follicle. So all these cases antagonist can be used. So you see here the results of again gonadotrophins with antagonist, again in selected group of patients. Don't use it in all the patients, but in selected group of patients, when you see a follicle 15-16 mm in size, you give gonadotrophins and you also give antagonists. So you give antagonist, you suppress the LS surge, you're giving gonadotrophins, you're giving FSH to the follicle. So follicle is growing, no LH is coming from the body because you have given antagonist, and then you give SCG and trigger, and then you do IUI 36 hours later. So should you do a luteal phase support in these patients? If we think logically, scientifically, they do have a corpus luteum, right? All these patients are ovulating, they have a corpus luteum, but since we are anyway using lot of progesterone even in spontaneously conceived patients. I think when we are using gonadotrophins, it makes it more productive or maybe better pregnancy rates if we do a little bit of support to the luteal phase. We can use just progesterone in the luteal phase support. So so this is how the gonadotrophin should be always maintained in a cold chain. Preferably try and give injection same time, 1 hour plus and minus does not matter. And if you have reconstituted, then you use the entire injection at the same time, and it should not be kept in the fridge. So go very, very slowly, start with lower doses of gonadotrophins, and only then later on, maybe once you get more and more confident of using gonadotrophins, then we can use it as we have discussed already. So thank you very much. And if there are any comments, I'm ready to take it. Thank you very much.
It was wonderful presentation with all the practical tips, and we really thoroughly enjoyed your presentation. Thank you so much.
Thank you, madam. Thank you.
Thank you, ma'am, for that great talk, as always. So with this, we move to the next session, where Dr. Dhwani will be talking on intrapartum care. I would like to invite our next chairpersons for the session, Dr. Radhika Chavia and Dr. Milind Wadekar. So I would like to take this opportunity to introduce Dr. Radhika. Can we have her CV? Yeah. So she is currently the secretary of Rajkot OBGYN Society. She has completed her MBBS from Baroda Medical College and DGO from Ramachandra Medical College, Chennai. She's been doing private practice since she was in Junagadh for 3 years, and currently she is at Bhakti Women's Hospital since 2011. She's also at Javia Hospital, Rajkot since 2019, and she has special interest in fetal medicine and fetal ultrasound and obstetrics. I request Dr. Amol Lunkad sir to introduce the next chairperson, Dr. Milind Wadekar. I think if he's not there, then Charu ma'am, could you introduce Milind sir?
Yeah. So Dr. Milind Wadekar is a young gynec endoscopic surgeon, and he's youngest to do the diploma in gynec endoscopy at the Kiel School of Endoscopy in Germany, which so many of us are fellows of. He has done his endoscopy training with Dr. Neeta Varti, again a very highly acclaimed teacher. He has been the ex-assistant professor at the Medical College in Surat. He's looked after the Surat OBGYN Society as secretary for the year 2013, 14 and 14, 15. Wow, that must have been quite, 2 busy years for you, Dr. Milind. He has conducted the first office hysteroscopy workshop in Surat with Dr. Usama Shauki in December 2015. Organizing chairperson of the hysteroscopic workshop at SOGOG Annual Conference 2016. VP of the Jain Doctors Federation Surat. President of the Surat OBGYN Society for 2019-2020, and he has so many other credentials to his name. So Dr. Milind Wadekar, welcome. Thank you for accepting to be the chairperson today, and over to you, both of you, to conduct the rest of the scientific session.
Hello.
Yes, doctor.
I'm audible, right?
Yes.
Okay. Thank you. Thank you for the introduction. Thank you, Pune Obstetrics Gynec Society, for involving Rajkot Society. It is a pleasure to be a part of this cutting edge webinar. So now our topic is on intrapartum care. Though it is very basic, yet very important topic for an obstetrician. I would like to say that especially for this kind of topic, who else could be a better one to talk on rather than a great academic experienced person. So I would like to introduce Dr. Dhwani Desai. She is an associate professor and unit head in obstetrics gynec department at Government Medical College, Surat. Studied her MBBS and MS from GMC Surat. She has been teaching since 15 years. She has done a fellowship in a advanced course in medical education, co-coordinator of medical education unit since 2022. member of Scientific Review Committee, Workplace Harassment Committee. She has special interest in high-risk obstetrics, laparoscopy, oncogynec, and medical education. Over to you, madam.
Good evening, everyone. First of all, thank you so much, Dr. Radhika, for generous for my introduction. And thanking you, Dr. Madhura, and other esteemed members of Pune OBGYN Society, as well as Arpit ma'am and other members from my own society for giving me this opportunity. I'll just start with my presentation. So basically, intrapartum care, joyful motherhood. What we are catering today about this presentation is about what is program labor actually. So, is this slide seen? Okay, thank you. So, program labor, programming anything will definitely make our life comfortable. As you all know, being obstetrician, we all know labor is a natural process. What is our job? Is to observe it very skillfully so that if anything goes wrong in between, we can intervene at a particular time so that the high risk complications and serious morbidity can be avoided. Okay, so by programming the labor, it has many added advantages that can be utilized to have a good maternal and obstetric neonatal outcome. If we go into history, the program labor is an indigenously developed protocol for labor management, developed long back with the dual objective of providing pain relief during labor as well as reaching the goal for the safe motherhood by optimizing obstetric outcome. So, how to achieve this by programming the labor? Basically, it has three main pillars. Now, these three pillars are first and foremost important is providing optimal pain relief. We all know, being obstetrician, how painful it is to underwent a mother to have a labor pain, especially when it is an active phase and second stage. So, by providing optimal pain relief, and I know all of the people, I mean, all obstetricians, team gynecologists are using one or the other way to relieve the pain, especially in the era of epidural analgesia. So today's focus is on other than epidural analgesia, how can other analgesic or antispasmodic can be utilized to an optimal pain relief to a mother so that she can enjoy a joyful delivery as well as reduce the complication which may occur due to pain, exhaustion, inefficient bearing down efforts, and many other issues we all were very well known for that. Ensure adequate uterine contractions. That is by doing active management of labor. And of course, when we are doing all these things, we have to keep the patient in a close monitoring in terms of I can say Brahmastra for us, that is partograph, so that we can all have a close look on all the events which are going on during labor. Now let us see what I mean to say by all these three pillars. Active management of labor is a concept which is, advanced by the Irish group, which is actually an old concept. O'Driscoll and Scully reported that it is advantageous to have the management of the labor in an active way. We all must have heard about active management of third stage of labor. But apart from that, I am talking of active management in the active phase of the labor. This will definitely give us the result like shortened labor, as there is the labor durations are short, the consequences like fetal distress and others are also less, and there will be improved obstetric outcome and lower cesarean section rates. Not only this, the many studies and researches have shown that by utilizing this protocol for program labor, in which the active management of labor is the prime component, it will help in preventing infection, dehydration, and ketosis in mother, exhaustion of the mother, disillusion in the mother, and definitely ultimately the fetal distress. So overall focus is to improve maternal and fetal well-being. And of course, I am not going to forget that each and everything has to be documented either by using a partograph, that is a modified WHO partograph, or the newer one, and not so new, but still new to many of us, that is the WHO Labor Care Guide, which not only take into care the all components of partograph, but it has also included the events specifically happen in the second stage of labor, as well as the component of respectful maternity care. Now, if you're talking of the original program labor study, they have included the patient age group between 21 to 30 years, all low-risk patients without any identifiable medical or obstetric complaints, provided the admission test, labor admission test is satisfactory, that is reactive, and patient is properly counseled and the consent is taken. So, as you see, the patient selection itself says that it has to be applicable to all low-risk patients without having any morbid conditions. Now, the medication for this program labor has to be begin only when the patient enters the active phase of labor, which we can definitely define by either a cervical dilatation more than 3-4 centimeter and the effacement more than 50%, a good moderate to good frequency of uterine contraction, that is 3 to 4 contractions in 10 minutes, with each of this contraction lasting for 35 to 45 seconds. And of course, there should be no clinical suspicion of cephalopelvic disproportion. Then and only then, the activation of this protocol has to be done. Coming on to the medication use, as I said, the prime important is pain relief and active management. For pain relief, by providing various drugs in an optimal dose, which is coupled with antispasmodic drugs, which will help in cervical softening, yielding, and dilatation to moderate driving forces, which ultimately land up in a pain less, shorter duration of the labor, which is a pleasant and a very good experience for the mother. And looking to the advantage of the protocol, this protocol provides the benefits of drug synergism. What happened here? We are, utilizing 2-3 drugs altogether. We'll see the protocol later. So the synergistic action of this drug is helpful in number one. We are using the very optimal, minimal doses, and due to that, the side effects are also less. But along with that, we will achieve whatever we want. That is a good progression of the labor, as well as safeguarding to the mother and the fetus, because the amount of the drug which has to be utilized in the program labor are very low and in a diluted manner. Looking at to the protocol, start an IV infusion line with 5% ringer lactate solution, about 20 drops a minute. As I said previously, if the contractions are moderate to good, that is 3 to 4 contractions, then that will be okay, nothing to do. But if necessary, we may add 2 units of oxytocin to the drip, or we can give the tablet misoprostol to ensure optimal labor pains or uterine contractions, resulting in progressive labor. Along with this, dilute an ampoule of 30 milligram of Fortrin, that is pentazocin, with a diluent like either normal saline or distilled water, and similarly dilute diazepam also in 10 ml of diluent. Now, both this diluted drug has to be given in very low dose. Administer just 1/5 of this drug, that is approximately 6 milligram of Fortrin and 2 milligram of diazepam, slowly in the bolus form through the tubing of the infusion line. This is at the start when the patient enters the active phase. Along with this, administer injection tramadol in the dose of 1 milligram per kg body weight, sorry, intramuscularly, along with any antispasmodic of your choice, like injection rotavirine or injection enapotan or buscopan or apidocin, as per the preferences of the gynecologist. Now observe the progress of labor by proper documenting in the patograph all maternal and fetal parameters as well as the progress of the labor. Sorry, on basis of cervical dilatation and descent. Another one which is to keep in mind is when the patient is in advanced labor, sort of 7 to 8 centimeter dilated, and she started bearing down. At that particular time, it is the time to administer injection ketamine if required, if patient is exhausted and having lot of pain. And this also in a very diluted low dose. If I want to say about how the dosage is to be made, then here it is about 0.25 to 0.5 kilo per kg body weight injection ketamine. So roughly for a 60 kg of average, weight, it hardly comes to 15 mg. And dilute the drug again in the 10 ml of saline and admit it very slowly as a bolus. Subsequently, we can top up it every 20 to 30 minutes as and when required. And the last top up should be given after the birth of the baby. This will allow patient to relax after delivery, and for us, it is better to examine the uh, vulva, vagina for any other trauma which has to be taken care of and repaired later on. And of course, the management of third stage is according to the standard guidelines that we are following for all other deliveries. As we all know, yes, the proven obstetric analgesia, the gold standard is epidural anesthesia, but uh, it is, not possible to give in each and every patient, not possible to have an anesthetic whenever it is required. So, just replacing it by giving injection tramadol as well as ketamine, trust me, is a good alternative choice for patient satisfaction and excellent pain relief. Coming on to clinical evidence, before starting that, I just want to share when I was, given to discuss on the topic and some reference material was, shared by Mr. Prasad. I was very happy to see the one of the references my own medical college. The study was done under the leadership of my mentor, my HOD, Dr. Ragini Verma, madam. Few years back, we did this study of this program labor protocol on around 90 cases. Out of them, 62% of the cases were between 17 to 25 years of age, and primary para account for 50% of cases. And if I want to share the results, it shows that 74% of the patient experience substantial pain relief. Out of them, 10% have shown the excellent pain relief. So it was really, commendable and remarkable, showing patients having such a good pain relief and having a pleasant experience for labor. Out of these all patients, 97.8% patients had normal deliveries. The rate of cervical dilatation which was achieved was 1.9 centimeter per hour in primary and 2.8 centimeter per hour in multi. So it was again really a good if we compare with the control. Maternal vital parameters were not affected. Yes, there are few minor side effects like nausea, malaise, and this is due to the utilization of the medication. But again, these side effects are not statistically significant, or neither they are any serious side effects. The ease of administration, the need for minimal patient monitoring with systematic analgesia program labor protocol is highly acceptable, and that is what we have observed in our study. Let us see a few more evidence. This is the chart showing the original Dr. Daftari serve protocol. And if we compare here the study group as well as control group, we can see that there is quite significant reduction in the mean duration of active phase of labor. That is 5.2 hours in control versus 3.5 hours. Mean rate of cervical dilatation is also quite good. That is 2.5 centimeter per hour, which results in overall shortened duration of the second stage of labor. Along with this, that is the duration of third stage of labor is quite less. That is, if we can compare, the control is of 15 minutes, whereas in study group it is 3.5 minutes. Pain relief score is again excellent and substantial in around 80% of the subjects, and that is really good. Looking forward to few more references, this is also an Indian study. Here also you can see that whether it is we are talking of cervical dilatation or we are talking of the active phase duration or pain relief score, each parameter is showing statistically significant positive effects whenever there is a study group that is in the program level. Yes, again here there are few complications in the form of side effects. Minor side effects like nausea, vomiting are there, but still, as I said, none of them are serious or statistically significant. This is sort of a meta-analysis showing 13 studies, which is scattering by different, observers over a period of time. This involved 1995 women included in this random meta-analysis, and this also have shown that the antispasmodic reduced duration of first stage of labor by an average of 74.34 minutes. That is quite a significant reduction, we can say. Again, one more study which is also showing same the duration of first stage and second stage and third stage. All these are decreased in statistically significant manner. Obviously, along with a very good rapid rate of cervical dilation. One more thing I want to add that along with yes, the rate of cervical dilation increase, a few of the studies have compared the cervical tear and perineal tear also, but there are no changes in them. So it is not a sort of a precipitate labor. No, the slow gradual rise, but at a good, reasonably better rate. That is what is important. Talking of few more study, one more is effect of welfamide bromide in accelerating labor. Again, the study has shown that the median time for cervical dilatation was quite good comparable to the control groups. And the study was specifically done in the nulliparous women. Few more studies to add on. This is the study especially done to compare the side effects. And again, the same things, yes, side effects were a little bit more, but the significance is not there. And they are almost not statistically, any of them were not statistically significant if we compare with those patients who are not received the antispasmodic. No statistically significant adverse drug reaction. Many more study we can, I can add on to this, which are showing the importance of program labor, where initially those thought that the side effects are more, and that is the reason for worried in people not opting for program labor. But I can say we have a number of examples in studies and meta-analysis which have shown that program labor actually is advantageous in a many ways. Just to summarize, shorter labor with substantial pain relief, significant amnesia of painful events of the labor for mother, average blood loss was also less, the duration of all three stages of labor were markedly reduced, obstetric management simplified, lowering the incidence of operative delivery, and there is no difference in the neonatal mobility. I mean, they were as comparable as that of control group. So that's what I want to say. Programming the labor will definitely help mother in improving mother as well as neonatal outcome, and it will be helpful for the obstetrician also. Thank you so much.
Thank you, Dr. Dhoni. That was fantastic. A joyful motherhood would also mean a joyful ending for the doctor too, because eventually that is what you are also there to achieve. Thank you very much for the talk.
Yes, as especially I would emphasize on what you had said about partogram. Actually, as a private practitioner, most of them now are not following the partogram, but actually we should, because and that also is mostly like we are plotting a partogram, but that is being plotted by the nursing staff. We need to teach them properly where and how to plot, because sometimes they do make a mistake in that also. And it is even helpful when we want to convince the patient for cesarean, because if we see if it is going beyond the alert line, and it becomes easier if we are clear showing them, see, it is even
Yes, you
here
can
it is
clearly
showing.
show that this is what it is crossing the action. And I must say, if you go through the labor lecture guide, the WHO has published recently, it is again a fantastic. It is just a modification of partograph, but it includes the events in the second stage of labor. So what I feel is for all those second stage issues like second stage descent problem, or when we have to take the patient for cesarean section for second stage issue, these all issues can be taken care of in the WHO this labor care guide also. So we have just introduced in our labor room. We have started using, even my residents are also very well versed with the old modified WHO partograph. So shifting them also to labor lecture guide, which is starting from 5 centimeters, is a little bit difficult task, but slowly we'll move forward to a better version of the partograph so that we can provide a better care for all those mothers.
Yes, definitely. So it was great, excellent, basic and everything covered.
Thank you, Dr. Dhwani. Thank you for that. And how many of us practice the
ma'am.
programmed labor, actually?
Pardon, ma'am?
How many of us actually practice programmed labor, I said?
Ma'am, if I'm talking of my own, as I said, we already did a 2-3 years back good study. I mean, we have given access to resident also, and we have have an excellent observations and result while doing the program labor.
Fantastic. Thank you so much. Practical experience always counts and matters.
Yes, ma'am.
So with that, I think we come to the end of this webinar. And two very important and interesting topics have been covered in great detail by two excellent faculty, Dr. Meenu Agarwal and Dr. Dhwani Desai. And we were fortunate and blessed to have great chairpersons also for the same, Dr. Archit Vachani, Dr. Chetna Shah, Dr. Milind Wadekar, and Dr. Radhika Javia. I sincerely thank all of you for sparing your valuable time and being a part of our webinar. We also wish Dr. Meenu Agarwal all the best wishes for her future endeavors. We all know that she's contesting for the post of Vice President Foxy, West Zone, and we earnestly request all of you to kindly support her candidature. We can all see that she's such a highly intelligent, international level of faculty, doing amazing work for the last more than 30 years. And she has her leadership skills, which have been already demonstrated in Foxy as well as in POGS. And so we request you all to kindly support her candidature. We also take this opportunity to thank BSV for arranging the platform for this particular cutting edge webinar, especially Mr. Prasad Kulkarni. And of course, our young Dr. Madhura Kulkarni, Kulkarni Kelkar, in spite of her personal and professional commitments, she always makes sure that she is a part of our webinar and makes sure that she pursues each and every one for their CVs and pictures and gets the flyer ready in time. This webinar would not have been possible without the support of Pune Obstetric Gynec Society, of which Dr. Aarti Nimkar is currently the president, Dr. Meenakshi Deshpande is general secretary, and Dr. Amol Lunkad is the clinical secretary. They are looking after the POGS with great elan. And thank you, POGS, for giving us the opportunity to continue performing these cutting-edge webinars with all the societies. And thank you for participating in it wholeheartedly. I also thank our esteemed guests of honor, Dr. Deepak Bhagde sir and Dr. Sudhir Shah sir, for kindly consenting to bless this webinar. So with that, I think in a very timely manner, we've come to the end of this extremely academic session. Dr. Meenu, would you want to say
Yes.
something?
First of all, Dhwani, that was a very, very nice talk that you gave. It was a very pleasurable talk. So, a lot of good take-home messages. So, very nice. And thank you to again Deepak sir and Sudhir sir for honoring us by their presence. And of course, both Surat Society and Rajkot Society. So, thank you to the president and secretaries of both of them to give us their time to chair our sessions. So Dr. Milind Wadekar sir, Dr. Chetna Shah, Dr. Arpit Vachani, and Dr. Radhika. So all of you, very nice to have you on this platform. I think let us meet sometime in person later, maybe sometimes. And but till we meet in person, I think it's good to at least meet virtually. So it's quite nice to be with everyone. And in fact, being in the same city, Charu and I also meet only virtually every week. We don't get to meet each other hardly. So it's really nice. I think these webinars are nice sometimes. Of course, this should not be the only way to meet. So thank you very much from on behalf of Pune OBGY Society to both the societies and to both our honorable guests and chief guests, both of them. So thank you very much. And thank you for appreciating and good logins, almost close to I think 100 logins today that they had, so which is very nice. So and every time we cross these 3 digits every cutting edge webinar, so which is nice. So thank you. And thank you, Madhura, for coordinating. This is a lot of work, collecting the CVs and making the whole flow of program. So Madhura, very well done. And thanks a lot. And I can't thank, not, I mean, thank is a very small word, Charu and Vaishali. They are my right and left hands, and they are just there for everything that that is going on in my life at the moment. Thank you.
Thank you. Thank you.
Thank you, ma'am. Thank you so much.
And
Good.
thank you, Mr. So thank you, Mr. Prasad. No, don't stop the recording. Your thanks should go to you and BSV team for
Yeah.
tirelessly doing it week after week. And again, we keep bothering you, telling you change this, change that. And thank you so much. Even when you're on a vacation, on a holiday with family, I keep bothering you. So thanks a lot for
Thank you.
this. Yes.
Milan, you can stop recording. And